Sir, good evening everyone, sir.
Please wait. Wait for 5 seconds.
All right. Anant, you want to start or you want me to start?
No, sir, please start.
Tell me when we go live, Manish ji.
Yes, sir, we are live.
All right. So a very good evening, my esteemed colleagues, mentors, friends. Of course, it gives me such a great pleasure to welcome you to all to this dedicated webinar. Now, when I say dedicated, it is because it is to advance the frontiers of ophthalmology, which has by itself been at the forefront of transformation. Whether it was the invention of the ophthalmoscope, the revolution that phacoemulsification brought in, or the cutting-edge era of AI and robotics that we're now entering. So now each of these milestones was not made possible just by science, but by perhaps the vision and the courage of innovators who essentially dared to think differently. And the kind of world that we live in, it is the innovators who drive progress. They help us see beyond the limitations of today, making eye care more precise, more accessible. So as we begin this dedicated session, let us kind of celebrate that curiosity and the creativity that keeps our drive and field alive. Let us be inspired by all of these lovely speakers today who've spared their valuable time to share with us, because these are the ones who push boundaries, challenge norms. They create solutions into bringing new light into millions of lives. So for this, I essentially like to thank our President of Maharashtra Ophthalmological Society, Dr. Shirish Turatsa, for thinking of this innovative session, which we shall, of course, continue at Moscone, Goa. I also like to congratulate Dr. Anand Bhosle and Dr. Rahul Baile for not just innovating themselves, but also taking the efforts to curate this amazing program. So together, along with all our speakers, which is Dr. R.C. Shah sir, Kakadia sir, Neha ma'am, Dr. Jeevan Ladi sir, Sohel sir, Anant himself, Rahul and Dr. Pankaj, we have a lot to share and learn and hope to inspire more people to take up this mantle of learning, collaborating, and innovating. So with this, I would like to welcome Dr. Shirish Turatsa, who is the President of Maharashtra Ophthalmological Society, to give his opening remarks on this wonderful session.
Thank you, please, sir. Am I audible? I'm traveling because I'm traveling.
Yes, sir.
Am I audible?
Yes, sir.
Yes, sir. Yes, sir.
Yes. Good evening, all. On behalf of MOS, I welcome you all to this webinar with a difference. And friends, these are all innovations done by our own members. And these all members are our gem of our society. It is our my society. It was a long time idea of our team that we should provide them a very good platform and to call them together and to do their felicitation. These are people who made us proud. These are people who dare to think differently and challenge the status quo and to provide a simple solution to the complex problems. We often look at the international conferences and global pioneers for the innovation, but today we turn our spotlight onto our own innovators. And friends, MOS is committed to the fostering culture of innovations and research, and in future also we are committed to do it so. Without taking much of a time, let me hand over the proceedings to the chairman and the moderators. Thank you.
Thank you so much, Turat sir, for
I think there's some network issue with Dr. Anand. So Dr. Rahul Bele and Dr. Anand will be our moderators for today.
So I would like Dr. Jeevan Ladi sir to start the proceeding. He is the chairman for today's session.
Hi, everybody. Such a pleasure to interact with MOS, which is my parent body, and been working there for the society, managing committee for almost 17 years. And it's always pleasure to be in touch with you all. Without much ado, let's start with the innovations. And who is the first person, Dr. Rahul, to start with the proceedings?
So the first talk will be, I suppose, with the doctor. The
Kakadia?
first talk will be Kakadia sir. Dr.
May I
Kakadia sir is eminent ophthalmologist, and he has lot many innovations which will definitely help the ophthalmologist and all the patients also to get the treatment at a very cheaper cost. He has lot many innovations. I cannot enumerate the innovations by 1, 2, 3, 4, 5. He has many. So, Dr. Kakadia sir, you can just start your question.
Thank you very much, Dr. Jeevan Ladi sir and Dr. Shirish Thorat. Should I present from my computer or I have sent the video to the AV team?
Yes, sir.
So
Try
you-
to control from your end only.
From my end, okay, fine. So I will share. Is my screen visible?
Yes, sir.
Okay. So this is a voiced PowerPoint presentation, so I'm not going to speak. The entire PowerPoint is narrated with precise details, so I'll just start. Hello, dear friends and colleagues. Today we are very happy to introduce to you Omega Ring, which is a very nice novel pupil expander. With increasing diabetic population and increasing life expectancy
Yes,
in
sir.
India, as well as increasing prostatism, much more often we get small pupil hard cataracts. If we don't use some form of pupil expander, often we end up in complications such as these or like this. So we have recently innovated Omega Ring. It looks like this in the front view and like this in the side profile. First, we keep the ring on cornea in such a way that these 4 dialing holes are facing frontward, anteriorly, or skywards. This soft, silky, smooth, and feather-light ring can be inserted just with Leicester hook and can be engaged into the pupil just with the Sinskey hook. Change of hands and engaging the 2 remaining pillars with the Sinskey hook, and then bringing the pupil into the center of the cornea. Alternatively, we can use Osher Y hook or Kuglen hook. No other special injectors or dedicated instruments are needed, and minimum incision size is 1.8 mm. This ring gives nice 6 by 6 mm square pupil, well centered. So we get a nice 4 sides as guidelines to do 5.75 mm diameter round capsular axis, which also is well centered. After IOL implantation and before visco wash, disengagement of the ring is also very easy just by the Sinskey hook. Ring removal is also very easy just by the Macpherson forceps. Please notice that the pupil shape is back to normal exactly as it was at the start. This ring will not budge no matter how much it is nudged, accidentally or intentionally. Even if we push thick visco cannula underneath it and nudge or try to move or disengage, it will not budge or disengage. Even if we intentionally try to displace or disengage the ring by phaco sleeve or tip, it will not move. It stands firm and still like Black Cat Commandos of PM or President of India. The ring is so nicely malleable and so resilient that it remains stable and steadfast even when rammed, thrusted, or jolted. We can even do whole phaco procedure from underneath the ring. Even with a slightly torn phaco sleeve, the ring will not get dislodged. Of course, this stunt is just for the demo of stability. Please don't do it. Even if we do entire bimanual IA from underneath the ring, it will still remain so stable. You can try this. Here, during the IOL implantation, I am deliberately trying to dislodge the ring with the cartridge tip, quite forcefully and jerkily also, but the ring stays firm like an Indian Army soldier standing on attention. This is our Autofocus Pro, a big 6.3 by 7.5 IOL with serrated haptics. And as we can see, the ring is so loyal that it does not leave its job position in spite of IOL haptic first trying to kick it and then trying to drag it. Many a times, pupil is fairly okay dilated when we start the surgery, but pupil starts to constrict during the surgery. This ring can be implanted at any stage of the surgery. In the aphakic stage, we just have to fill the bag with Elon GV or something like that to mimic the presence of a soft nucleus. The ring is so soft, smooth, gentle, and kind that there is never any worries about the intercapsular rim getting torn or ripped off. One more case of mid-surgery ring insertion, which is easy, safe, sure, and secured. Even in a very small and tight pupil, we never need to do sphincter stretching. In fact, it is not advisable in general. And because this ring opens the pupil without much sphincter tears, the pupil comes down to original size and circularity as soon as the ring is disengaged. In over 900 eyes over last 36 months, we found no additional corneal endothelial cell loss in any case, no iris damage, no intraoperative dislodgement, no iritis, nor TAS, and no CME in any of our cases. This ring will be available in two sizes, 6 mm for phaco and 7.5 mm for MSICS. It is so easygoing that practically there is no learning curve. Even phaco trainees can learn it in one case and master the tricks of it in 5 to 6 cases. Both these items are made from the same reusable material so that per case cost can come down significantly. The design of this ring was divinely inspired on 15th August 2016 in a flash of a moment at the time of Antim Darshan of Param Pujya Pramukh Swami Maharaj, while making the last garland for His Holiness from white 4-petal flowers, the design and patent of which is being blessed by Param Pujya Mahan Swami Maharaj. Another important source of inspiration, of course, was Dr. Elijah Kakadia's 4-petal flower clover ring. By the way, thanks to the Omega ring, I could gift her many more rings. And we are sure that you can also do the same for your sweetheart and or for your better half. After completing the pilot clinical trials, we are now waiting for final approval from the Indian FDA CDSCO for commercial availability. In near future, Omega rings will be commercially available from Excel Optics, Chennai. The name Omega denotes the pupil size, which goes from mini to mega and is back to mini. And the pun fun is Omega. And there's also Om in the beginning. Well, mega thanks from Omega. Many special thanks to MIS. Thank you all very much for your kind attention and patient listening.
That was a fantastic presentation,
Thank you.
equally entertaining by Jagdeep Kakadia sir, who has been well known nationally and internationally for his innovations. Thank you so much, sir.
Thank you.
Can we move to the next talk by Neha ma'am, please? Neha ma'am has done her MS from Mumbai KM Hospital and has a experience of operating more than 33,000 surgeries with special interest in refractive procedures, now performing femtosecond assisted catheter surgery and has won multiple awards for her own innovations. Actually, I will be sharing screen for Neha ma'am.
Dr. Anand, I've shared you one other video just now. Can you play that? That's more interesting how the tip was thought about.
Okay, ma'am. I'll just copy
Yes,
and
please.
then transfer. Please give me one moment.
It's a smaller presentation and it's newer.
Okay.
Good evening, Dr. Ladi, Dr.
Hi, ma'am.
Pankaj, Dr. Kakadia, everybody. I'm on my
Hi,
phone
ma'am.
and I don't have a laptop. Dr. Sohel, Viral Bhai.
The dual purpose.
Yes, you can play it.
Is my screen visible now?
No.
No.
No, sir.
All right.
Yes, sir. Now it is visible.
This tip, Dr. Neha Tolakya. The making of the tip. First question that came to my mind, why can't a phaco machine or a phaco tip just engulf the cataract? But this was the result. I got a stamp-like edge, and one surely can't cut an IOL like this. Then I made the tip like a screwdriver so that I would get straight edges. So this was my attempt to make straight lines and straight edges, and this is what I got. But who's going to hold the IOL vertically? Then an MR left this plasticine with me and I was playing around with it and I'm instructing the person how to make this tip. And this is how it would cut through the IOL. And when it actually came, and this was the first attempt at slicing the IOL, it was just sheer joy. Then I made the angle different and made it perfect. The IOL slicer, stop cutting, start slicing. So this tip is attached to the phaco probe and one can just slice through IOLs just like butter, almost like a hot knife through butter. It takes just few seconds. Taming the hard cataract. Dr. Pankaj Lande from Amravati found out this other use for the tip where one stabilizes it and uses it to cut hard cataracts. So one has to prime the phaco machine and then with your original tip and then attach this tip. There are forceps which go through the side pot and this is how it is cut in vitro. All you need to do is just press the foot pedal. The temperatures were checked. They were the same, just like a regular phaco tip. The power is 30, aspiration vacuum 0, irrigation is on. You can use it for broken IOLs to remove them, opacified IOLs, subluxated or dislocated IOLs, halos and glare intolerant to the patient, refractive surprises, especially post LASIK, and we will be seeing more and more of those. Many times when the lens just shoots through, punctures the PC, or you have, after a beautifully done case, very disheartening to see how the IOL breaks. Now one can explant it by opening up the incision, creating astigmatism, or the twist and out technique, which you cannot do in case of a PC rent and requires quick skill, or you can bisect it with a pair of scissors. All this can lead to edema and endothelial damage. Now coming to the second use. This is a very hard cataract and you can see how when you do a horizontal chop, basically you're stabilizing with the right hand with a phaco vacuum and moving the left hand towards the center with the chopper. Here you're doing it the reverse. You're stabilizing it with a stabilizer with the left hand by going around the equator and then with the chopper or the same tip one can enter into the core of the hard cataract and dissect it. Now see, this first cut has been made mechanically, so you can see white fluffy edges. And the second one is made with the ultrasound. So you're seeing clean, sharp edges. You can see the fluffy edges of the first cut. After this, each quarter is bisected and one can manage to cut the hard cataract. This is to give you an idea of how hard the cataract is. If you see a mechanical chop so difficult it is. But with ultrasound, using to cut the cataract becomes easier. So these are the two uses. One can keep it like a vitrectomy cutter, ETO it and keep it. You never know when you will need it. And it can always come of use. A special thanks to Dr. Pankaj for innovating the second use.
Excellent presentation, ma'am.
Thank you.
May I request our honorary treasurer, Shon Chinchodi sir, to introduce our next speaker, Dr. Sohel Khan sir.
Good evening, everyone. Very good evening. Dr. Sohel Khan is very good friend of mine. He did his MS and DNB. He was in Shankar Netralaya for FMRCF, and he was in Arvind Eye Hospital also, and LVF Hyderabad. He is now at present is Professor of Ophthalmology at Dr. SV GMC Nanded, Maharashtra, and he is a patent holder for the novel pre-chopper in cataract surgery. Sir has been awarded, and achievements are the winner of World Webinar in Cataract and Refractive Surgery, WWCRS 2020, then winner of AIOC 2020 Gurgaon, then best video for the best video and best technique award in Big Standoff Challenging Video Symposium. He has been awarded as an outstanding ophthalm teacher of India, then patented a novel Sohel Khan's pre-chopper for cataract surgery. Video section in Cannabis International Forum 2025. He is a quiz winner of BOA 2016. Then in a quiz of 2017. Currently a review of video section in prestigious Indian Journal of Ophthalmology, that is IJO. He being as a faculty in AIOS, MOS, and BOA. So here we are presenting Dr. Sohel Khan. Thank you.
Good evening, all. Thank you very much, Dr. Sean. I'm also very much thankful to Dr. Thorat sir, Dr. Piyush, Dr. Viral, and of course, Dr. Anand Bhosle sir for taking a lot of efforts. I will be presenting my pre-chopper use in hard cataract, but because everybody knows that it was designed basically for disassembly of the hard cataract, I'll try to alter the sequence of my presentation, which is for 8 minutes, by sharing the use in soft cataract, because at times soft cataracts are also intimidating. And I'm also going to show a small clip about the use in MSICS, which will expand the horizon of the presentation. Is my screen visible? Hello?
Dr. Anand, you please stop sharing your screen so that his screen can be visible.
Is my screen visible?
No, Sohel, wait. Dr. Anand's screen is visible.
Just a second, sir.
Yeah.
You can share now.
Is my screen visible?
Not
No,
yet,
sir.
Sohel.
I have stopped sharing. Dr. Khan, please share yours now.
Dr. Ramesh Shah has joined. So welcome, Dr. Ramesh.
Now is it visible? Hello?
Not yet, sir.
No, not screen.
Sir, please click on the share button and then it will give a pop-up for you to start sharing.
That is what I'm doing. Share screen.
Once you hit share, there will be a share option in the bottom, and after that you can go to the respective screen what you have.
I think there is some glitch. If the next speaker is ready, then maybe he can start his presentation.
Rahul sir, could you please introduce the next speaker? Thank you.
Hello. So our next speaker is Dr. Jivan Ladi, sir. Dr. Jivan Ladi, sir, is a gold medalist during his MS. He was ex-past president of MOS, ex-chairman scientific committee of MOS. He was past president of Pune Ophthalmology Society. He has won Best Video Award in national conferences and Best Free Paper Award in three MOS. So I invite Dr. Jivan Ladi, sir, to start his presentation. So your screen is visible.
Hi, I would like to welcome you all and thanks to Maharashtra Ophthalmic Society. Can you hear me? Am I audible?
Yes, sir. Yes.
Yeah. Okay. So I would like to thank Maharashtra Ophthalmic Society President Dr. Shirish Thorat and all the office bureaus of MOS and Dr. Rahul Bell, Dr. Anand, Dr. Sean, everybody. I thank you all for giving me the opportunity to present this. So let's start with the presentation, the Ladi method of immersion scan for premium IOLs. This is a copyrighted technique with Indian government. This is the full certificate. It has already been published into peer-reviewed journal in UK. It received the Innovation Award in Moscow 2023 in Kolhapur. It was also taken as or given the best can say paper of the session in AIS conference. So what's the issue? We need to integrate immersion ultrasound scan biometry to the modern formula like Barrett Universal 2. Just hold on, please.
Hello.
Just hold on, please.
लेकिन मैं बता ही नहीं सका हूँ शेयर स्क्रीन करने के बाद भी समझ में नहीं आ कैसे करना लिख के तो कुछ भी नहीं आ रहा हाँ जब नीचे जो ऑप्शन है ना शेयर शेयर स्क्रीन बोल के आ रहा
So, sir, can you put your mic off, please?
So advanced formulae require axial length of the optical biometry. So we need to integrate immersion with advanced formulae like Barrett Universal 2, which is widely used. That's why it was used for this study. The two groups of biometry were made, immersion ultrasound, 100 cases, and optical 100 cases. Randomization and masking was done at a usual international standards. Only mandatory parameters of Barrett Universal 2 formula were used, that is axial length, antechamber depth, and keratometry. Optical biometry group, axial length, antechamber depth, and keratometry were taken from the optical biometer, while in immersion group, axial length was taken from an ultrasound machine in automated mode, while antechamber depth and keratometry was taken from the Scheimpflug camera, that is imaging system or a topography. The Ladi method is nothing but addition of 200 micron or 0.20 millimeter to the immersion ultrasound axial length. As you can see here, ultrasound cannot penetrate beyond internal limiting membrane, while Optical having a very thin fiber can penetrate and go up to the retinal pigment epithelium. The distance between these two is 200 micron or 0.20. This was a study done, which is online, a real-time thickness measurement from the internal limiting membrane to retinal pigment epithelium, where it shows that foveal thickness is 212, while central foveal thickness is 182. So obviously, average which was taken for this study was 200 micron or 0.20 millimeter. Both optical and ultrasound group parameters were entered into the Barrett Universal 2 formula. Study target was kept as a 0, except for one eye of a patient who were put with the EDOF lens, where 0.50 micro monovision was targeted. All the parameters of axial length, calorimetry, anti-jumbo depth, and A constant were entered into the Barrett Universal 2 formula. Postoperatively, best corrected visual acuity manifest refraction at post-op 1 month, 3 months, and 6 months was taken. Spherical equivalent at 6 months was calculated as a sphere plus half of the cylinder. The residual refractive error is a spherical equivalent minus target diffraction. Age, gender, pre-op visual acuity, grades of cataract between both the methods were not statistically significant. But interesting thing to notice is that most of the cataracts, say more than you can say 70%, were above grade 2 nuclear sclerosis. All types of IOLs were used in both the groups, that is monofocal aspheric thickness IOL, intermediate lens, monofocal toric lens, multifocal lens, toric multifocal lens, EDOF lens, EDOF toric lens, and continuous range of vision lens with or without toricity. In both the groups, p-value is not significant. Almost same distribution is seen in both the cases. Best corrected visual acuity, sphere, cylinder, at 1 month, 3 months, and 6 months in both the groups was more or less same, which is not statistically significant. Exact target refraction was achieved in both the groups, that is ultrasound method and optical method, that is 73%. While refraction within the range of plus and minus 0.5 diopter of target, spherical equivalent, the residual refractive error in both the groups were almost comparable and not statistically significant. A scatter plot with logically weighted curve, that is Lowry's curve, shows that both immersion ultrasound A scan and optical biometers were almost within the range of a target refraction. Difference in residual refractive error between the two groups was only 0.02 diopters at 95% confidence interval of minus 0.5 to plus 0.09. P-value again not statistically significant. Now, if you see Rhonda Wharton's study of USA shows that dense nuclear cataract, dense posterior subcapsular cataract, posterior polar cataracts, and wide macular cataract forms 22% of the cases, while in Indian scenario or developing countries, this is likely to be far more than that because of lack of awareness and people reporting led to us. People, those who are using even optical biometers, this is going to be beneficial for them because if the patient is demanding premium IOLs, this will help them. Many of these optical biometers give readings when in some of these cases, It is why? Because they use composite signals. That is, multiple signals are combined together and giving you a summation and giving you a reading. So it is nothing but a estimation of reading, but not a true reading. The true reading can be get only by the ultrasound. Barrett Universal 2 formula, Kane, Olsen, and the Hill RBS are the best formulas today for IR power calculation, but they need optical biometry axial lengths. As per the previous studies, optical biometry is more accurate than immersion ultrasound in calculating axial length, and that values derived from these machines may not be used interchangeably. With the Ladi method, ultrasound-derived axial length enhanced by 200 microns appear to overcome this problem, and the refractive outcome is comparable to optical biometry. This study is a randomized study, adequate follow-up, and relatively good numbers are there. To the best of our knowledge, there are no studies looking at ultrasound-derived axial lengths making it compatible with the newer IR calculation formulae like Barrett Universal 2, Kane, Olson, and Hill RBS. These are our references. Thank you.
Excellent talk, sir. Very practical tip, because in most of the cases, many ophthalmologists won't be having optical biometry. Excellent talk. Now I call upon the other speaker, Dr. Pankaj Lande, sir. Dr. Pankaj, are you here, Dr. Pankaj, sir? He has done DNB from DNB Ophthalmology, and he is a fellow of Cornea. He received many best innovation awards. One in IIR-SI in Afghanistan 2025. He was given a best video grant award in the same conference. He has awarded multiple awards at VOS, and his main interest is in cornea and cataract. So Dr. Pankaj, sir, please. Your screen is visible, sir. Sir, no voice. Pankaj, sir, your audio is not audible.
Please share screen audio.
Dr. Pankaj, if the screen audio is not there, you can give a commentary. Dr. Pankaj?
Audible. Pankaj, sir, you're not audible.
Dr. Pankaj? Can you hear me?
Dr. Pankaj, are you listening, sir?
Dr.
मोबाइल पे
Pankaj,
बता दो. Tell him on mobile.
I'm calling him, sir.
Sir.
Yes.
I think his local connection is very slow. His internet connection is very slow.
Please bear with us. I'm just helping Pankaj sir on the phone.
Till the time Dr. Pankaj comes on a line, can you take the next speaker? I think, is it Dr. R.C. Shah? Dr. Anand, please.
Yes, Archie Shah sir.
Till the time Dr. R.C. Shah is presenting, Dr. Anand, you can you connect with Dr. Pankaj and arrange the things if you don't mind.
Sure, sir. Can I quickly introduce Archie Shah sir, who actually doesn't need much introduction. Sir has more than 40 years of experience in ophthalmology with multiple innovations. He has notable innovations like Autofocus Pro, which is the world's first polyfocal IOL. He has multiple other innovations with Kakadia sir like OmniGlow, which have revolutionized the use of optics and microscopes in India and overseas. He was the first to insert iris claw on the back surface of an iris. He is an honorary teacher at the JJ Hospital group of hospitals in Mumbai and has trained more than 80 plus doctors for various anti-segment surgeries. Over to you, Arshisha sir.
The screen is visible now.
Then colleagues, today we are very happy to introduce to you.
Can you hear me?
Innovative way of doing perfect
Yes, sir.
with zero recurrence and zero complications. Without using any glue, stitches, plasma, or autologous blood. Using a specially designed large soft scleral bandage contact lens, which we have fondly named Terigo. Terigo is 18 or 21 mm diameter large soft bandage contact lens made from high water hydrogel material, which is containing nanosilver ions, which is a potent antimicrobial as well as a healing promoter. Please notice the difference between corneal bandage lens and the Terigo, the scleral bandage lens. This is how the lens is made available in a wide mouth glass bottle, which is sterilized by autoclaving at manufacturing. So the inner contents are already sterile. It is made by Silver Line Laboratories, New Delhi, India. Up to the step of dissection of autologous conjunctival graft with limbal stem cells is same as our routine surgery, and then using a colibri and McPherson suture tying forceps, the flap is inverted so that the epithelial surface is now facing skywards or upwards or the frontwards, and the flap is brought and set into its seat or pit, always keeping the donor side limbus oriented to the recipient side limbus. And with McPherson forceps, a sort of multi-point acupressure therapy is given to the flap to make it to stick to scleral bed. After patiently waiting for more than a full minute for the surface to dry up and the natural thrombin and fibrin to form good adhesion, we now spray the cornea with VSS, preferably with 1/4 diluted moxifloxacin, to check for the reasonably good adhesion of the flap. This water jet test confirms that the flap is well stuck. If we had not waited enough, the flap may not have stuck well. It will fold or move in the water jet test like this. In such case, deposit and repeat the acupressure and wait for a little more time to dry and re-stick the flap. Now, with a wet cotton tube swab, we take out the Terigo BCL from its bottle, which is then invertedly sprayed over the cornea and graft flap. It is like spreading a king-size big bed sheet, so we will need at least 3 or 4 hands to spread it. So the scrubbed assistant has to help the surgeon in this step. At this stage, if some air gets trapped under the pterygo lens, please don't worry. Just a mild pressure with cotton pad will remove most of the air. And remaining few bubbles will get burped out from 12 o'clock position when the patient sits up. Now, we put moxifloxacin drops over the BCL, and please notice that the graft margins, if has moved, can be nudged even through the BCL. BCL becomes more visible in the UV light because it absorbs and reflects UV rays. And then the speculum is gently removed, always under the direct and microscopic vision of the surgeon, so that we make sure that during speculum removal, either the lens or the graft hasn't moved from in situ position. Please remove the drapes also under microscopic vision of the surgeon, just making sure that the graft and the BCL both are undisturbed and are in situ. If the surgery was under peribal bar, the leads are then taped and patched for 6 to 12 hours. In topical surgery, we can keep the eye open right away because pterygo is there to protect the graft, and don't worry about the trapped air bubble. Pterygo BCLs are available in two sizes, 18 mm for hyperopic like smaller eyes and 21 mm for myopic like bigger eyes. This is the second day, 24 hours post-operative, and as we can see, the graft has already well healed and the lens is also in situ. This is 1 week post-op and on slit lamp under proparacaine topical anesthesia. We gently remove the BCL with McPherson forceps, and as we can see, the graft is already well taken up and has healed so well. The pterygo BCL covers all the three sites, donor area, graft, as well as corneal epithelial defect. So there is almost no pain or foreign body sensation, and all three sites heal much faster under the shielded protection of the pterygo, and the surgery also becomes faster, usually taking only 5 to 10 minutes. In over 5,000 cases done so far in 24 months by more than 200 surgeons, no graft loss, no graft displacement, no chemosis, and no infection in any of those cases. We fondly call this as cut, paste, and cover or cut, paste, and shield surgery for pterygium. Apart from 81 or 21 mm diameter, it can be made in any other chosen diameters also. It can be plano or it can also be made in powers in the range of plus 30 to minus 30 diopters. It is having more than 75% water content with the highest possible oxygen transfer capacity, the DK value, and it can be kept in eye for 24/7 for up to 3 to 4 months at a stretch. Pterygo lens is also very much useful in almost 15 other indications, such as phakic or pseudophakic bullous keratopathy, chronic, recurrent, and intractable filamentary keratitis, chronic and recurrent epithelial erosions. Another class of recurrent epithelial erosions, which are mostly incited and ignited by trivial trauma, mostly by fingernails or by paper or cardboard corners. They also heal so very well with pterygo. This lens is also a great help for irregular corneal surface due to spheroidal corneal degeneration. Just cover the spheroidal surface with BCL without any scraping or without any intervention. Pterygo is also a great help and a protection, in fact a must for Boston K-Pro as well as for Oro K-Pro for masking overfiltering trapped blebs. The soft pterygo works so well in upper or lower lid entropion, giving complete protection to cornea like a shield against errors. Please try it. Also in cases of trichiasis and dystichiasis, your patients will be so happy with pterygo. and also for congenital, traumatic, or iatrogenic, partial or total aniridia, or for cosmetic purpose, and also for masking irregular astigmatic refractions induced by keratoconus or radial keratotomy, post-intact rings and C3R, yield Murren ulcers, pellucid marginal degeneration, Terrien marginal degeneration, total or partial lamellar keratoplasties, post-injury corneal scars. In short, pterigo is an excellent buster of any kind of irregular astigmatism, and because of the large diameter, this lens will not easily fall off during shower bathing or normal activities. These are peer-reviewed publications about advantages of a large bandage contact lens for induction of fast epithelial healing. Pterigo MRP is rupees 3,000, hospital cost is rupees 1,500, and free samples are not possible. Contact number for availability. We have no financial interest. Thanks a lot, MIS, and thank you very much for your kind attention and patient listening.
I have used this lens in 6 patients of keratoconus. The longest implant in the human eye is about 8 months without removing it. All the 6 patients have improved significantly. In one of the patient who is a TV artist, she is so much dependent on this lens that every 6 months he forces me to remove and place the new one, and she's extremely happy. There are 2 patients which just come from Saudi Arabia post RK, where vision was only finger counting, and after putting this pterigo lens, one eye improved to 636, and other eye improved to 612, and he's on the contact lens for last 6 months. So these are some of the most important uses, even for the rehabilitation of the corneal disease like keratoconus, post-RK, irregular astigmatisms, and rest of things. And because you don't have to remove for 6 to 8 months, it works really wonder. And we are just trying to prepare it with the various powers given to them. We may not be able to help them in cylinder power, but spherical power will be definitely helping them so that their quality of vision will improve significantly. Thank you so much.
Excellent talk, sir. Superb. May I now invite our next speaker, Dr. Pankaj Lande, so that he can start his talk. Dr. Pankaj Lande, sir, please.
Arsi sir, please stop sharing your screen.
Is Dr. Neha Dholakia there?
Yes, yes, sir.
Neha, which softest cataract you can crack with your device?
We don't need it in that soft cataract, not required.
Not.
No.
So only the hard cataract, it might be very useful.
Yeah, that also Dr. Pankaj only will answer the questions. He's the champion at this.
And one more thing is there.
Mm.
Your forceps, no?
Mm.
Another forceps which is made by Epsilon.
Yes.
And it works wonder to hold the lens. If you can try that forceps.
Sure.
Really wonderful.
Okay.
He has made that new high hole holding forceps.
Okay.
It works. The grip with that particular forceps is
better. Okay, definitely. Definitely. We'll look.
Just I'll send it to you if you want.
Yes,
and
sir.
just try it, and I feel it is better than this.
Okay, definitely. We will change the forceps.
Okay.
Okay, thank you.
Pankaj sir, are you ready to go? I have your presentation. If it doesn't work, I can play it from my end.
Dr. Anand sir, I think you can share the screen and Dr. Pankaj can.
I'll play it from my end.
Welcome to Sri Netralaya.
Yeah, now it is audible.
a single-handed CTR injection system, which is very simple to use. Capsular tension ring is an important device used in cases of zonular dialysis, pseudoexfoliation, pediatric cataracts. It also helps in cases of high myopia, high hyperopia, small rhexis cases where you expect capsular phimosis to happen later date, post-uveitic cataract, post-traumatic cataract. It is also useful in toric IOL cases where it stabilizes the IOL and prevents rotation of IOL. So let's see how to make this single-handed CTR injection system. The components are very simple: a 1 ml tuberculin syringe and a 18 gauge IV cannula. Now, let's come to the steps how to prepare this. First, the metallic inserter of IV cannula is taken out. It has to be broken. In 18 gauge cannula, you can directly pull this metallic part and it will come out. Here it was slightly more stiff as I was using 16 gauge cannula for better demonstration and visibility. You can just twist this metal and it will break. Now I have a separate metal inserter for our injector system. Now take 1 ml syringe, take the plunger out of it, and the front rubber stopper is taken out. This rubber stopper will help us attaching the metal injector to a piston of 1 ml tuberculin syringe. Just pierce the tip of this metal into the rubber stopper and then bend it so that it will lock there. Once bent and locked, this rubber stopper is attached to the piston of 1 ml syringe, and this will be our inserter for CTR. If you insert this metal rod into the 1 ml now, it will go to the sides and will not come out easily through the center. So to overcome that problem, I have taken a silicone tip from IOL injector and inserted into the tip of this metal inserter. And this way, it will come out of 1 ml syringe very easily. This silicone tip will be taken from any disposable IOL injector. With this silicone tip attachment, now we will insert this into the 1 ml syringe, and the metal inserter will come out of 1 ml syringe easily. Now we can attach the IV cannula to it, and our inserter can go into the IV cannula very comfortably. It is very important that this metal inserter should come out of IV cannula from the tip. If that is not happening, you can cut a small amount of tip in the front. Here we are creating an air vent, because when I will inject my CTR into the anterior chamber, air may also go from the 1 ml syringe to the anterior chamber, and I don't want that to happen. So I'm just creating an air vent. Now we will do the ex-vivo check. This system is sterilized using the ETO after preparation. Let's see how this will take the CTR out. We have loaded the CTR with the help of forceps, and now I'm injecting the CTR into the anterior chamber. See how nice and comfortably it is coming out. Here you need not to manipulate with the left hand. to the distal eyelet of CTR. This system is sterilized with ETO and then used. Or the front IV cannula can be every time changed so that sterility is maintained well. This is the air vent which will prevent the air from 1 ml to enter into the anterior chamber. Now we will load our CTR. Loading of CTR into the IV cannula is not a difficult task. It can be done with the help of forceps. The eyelet is seen out of this IV cannula, and now we will insert this CTR into the bag. Now insert it into the anterior chamber through the main port incision. Go close to the rexis and start pushing and guiding CTR insertion in the bag. Once the distal eyelet is about to come out, go below the rexis and insert it directly into the bag so that you don't need a second hand. See it once more in second case. Hope this video will help you to understand and utilize this very simple, innovative CTR injector system, which is safe, easy to use, and single-handed. Do subscribe to our YouTube channel, Dr. Pankaj Lande, for more such exciting and
Excellent presentation, Dr. Pankaj. A very nice and innovative idea. Now I request our next speaker, Dr. Anant Bhosle. He has done dual long-term fellowship. He is trained at Arvind Eye Hospital, Coimbatore, and at Sir Charles Gairdner Hospital, Perth, at West Australia. He was investigator in phase 3 trial. He is an invited speaker nationally and internationally with papers in BR. He has multiple books, chapters. Dr. Anand, please start your presentation.
Thank you, Rahul sir, for the introduction. So today I'll be presenting more of a case in a form of an innovation where we use an artificial iris with toric implant along with a cortex suture for a trauma case. So whenever we have patients with globe rupture and we have patients with injury, we usually face these problems: aphakia, astigmatism secondary to scarring, aniridia, and secondary chororetinal sequelae like epiretinal membrane and incarceration of the retinal or choroidal tissue. So here we have a 69-year-old gentleman with history of fall who had a previous history of cataract surgery done elsewhere. And when he presented to us with injury, his vision was PLPR. So as we all would do, we took him to the theater with a Barrett speculum, and we can see here the ruptured globe with the site of injury. After doing a thorough peritomy, we could see a linear and ragged scleral tear with aphakia. So we repaired the limbus with vicryl sutures and make sure that the eyeball is formed. By slinging the muscles, we tried to search for any occult tears. None of the area showed any posterior tears. So at the end of the surgery, this was the picture. We have aniridia, aphakia, and a formed globe. At 3 months follow-up, we had this picture, and the problems we were dealing with: aphakia, total aniridia, and epiretinal membrane. So when we got a K values and refraction of the patient, we had this 4.5 diopters of cylinder, and the patient was improving to 612 parts with plus 10. This patient, being a physicist and very active at this point of time in his life, kept on insisting on visual rehabilitations. So we had here no iris, aphakia with very high cylinder. So what do we do for this gentleman? On Barrett's Toric, if we see, it is somewhere around T5 with a IOL cylinder of about 5 and 20 diopters of lens at 57 degrees. So what we decided is we decided to get an artificial iris created for this gentleman. We sent the pictures of this gentleman to the company with Kodak color patches, Kodak color control patches, along with the other eye, the right eye. And these pictures, once they sent to the company, they asked me to write an exam which I had to clear. Once that was done, they sent us artificial iris, and which was used for the surgery. This is a quick video through which we can learn how this was done. Now markings were made at the toric axis. Desired toric is at 57 degrees. And we have made two sclerotomy entries radial to the limbus. So these are the sclerotomies through which sutures would be passed. A peritoneal membrane is seen on the fundus, and it was peeled using an ILM forceps. You can see a healthy looking macula there. So the sclerotomies were made at 1.5 mm and 3 millimeters from the limbus at 57 degrees using a trocar. And this is an Envista toric lens of the suitable astigmatism. Vortex suture is passed through the eyelets of the particular lens at the junction of the optic and the haptic. The haptics are cut to make some enough space behind the iris and for anteroposterior stability of the lens. And this lens is the Gore-Tex suture is introduced through the main wound, which is a 2.8 mm wound, and the suture is exteriorized through our sclerotomies at 1.5 mm and 3 mm. This lens is folded using a Allergan hold and fold forceps and introduced and it is introduced via the main wound at 2.8 mm. The Gore-Tex suture is gently pulled away, and then we make sure the tension on the ipsilateral sides is equal so that the centration of the lens is perfectly achieved. Here comes the hero of our surgery, artificial iris. Now what I do here is I borrow a corneal trephine from my wife's library, which is 1 mm lesser than the white to white measured of this patient. So if the white to white is 12 mm, you reduce 1 mm, that is 11 mm trephine, and pass the sutures through the artificial iris. If we see, these sutures have been placed at 90 degrees away from the primary sutures of the lens. Gore-Tex suture is internalized into the vitreous cavity, and the wound is closed using glue. So this is the outcome at 3 months post-operative, where we have an eye with aphakia, which was corrected using artificial iris with Gore-Tex suture and a toric IOL. Now with minus 0.5 cylinder at 123 degrees, he is 612 as expected. So for a patient who had injury with such a squashed eye globe, at 3 months with this picture, we can give a fantastic outcome and visual rehabilitation with this novel technique. So the take-home message in this is accurate biometry and minimal incision techniques are of extreme help. Gore-Tex suture, as we all know, has been traditionally used in cardiac surgeries for wall replacements, is a fantastic biocompatible material, unlike polypropylene, which hydrolyzes because of the its own innate properties. And extreme trauma cases like these, we can use iris implants and toric file for visual rehabilitation. Thank you.
Sir, where do we get these iris implants?
Sir, we have a company called Human Aptics in Germany. I can share the email address of the concerned person. So all we have to do is we have to send the details of the patient and make sure it is not for cosmetic use. Otherwise, they won't send us the implant.
This
And what
iris, used cosmetically and it had a problem. That is why now they have banned it.
No, what I'm trying to tell you is, what is the approximate cost you are expecting, if you don't mind?
Approximately 1,20,000 rupees for two. So they send you two. Once we use one is standby. Once the one is used, we have to send back the unused one.
And it is of the same material, both of them, or they are different material?
Same material, exact same color. For in the bag, they come with the fiber, and for SFIL without the fiber. So in the bag also, so you have a traumatic aniridia, the cataract is still there, and the bag is intact, so you can put it into the bag, and instead of using morsures, segments or rings, this can be used as well.
And can we use it for albinism? Does it help or no?
Albinism, sir, no personal this thing. The diameter of the pupil is fixed, but I think it's a good idea to use it for albinism.
Just
Yeah,
one
but,
thought.
RC, there has to be pseudophakia or aphakia. Otherwise, this will cause glaucoma.
If you use it on the iris, there are a lot of studies which were done in Germany with this artificial iris, and it had a lot of problem because of the angle. Because if there is already an iris intact and you put this artificial iris, then there are chances of rise in IOP as well as endothelial damage. So they don't advise it to put as a cosmetic or on an iridia, albinic iris.
One TV artist heroine has gone blind because of the bilateral implantation of this in a phakic eye with natural iris, and this was put in the anterior chamber.
Yes, sir.
So it's only for the pseudophakia. And the problem with pseudophakic in the bag iris implantation is that eventually when the anterior capsule becomes slightly opaque, that opacity appears through the cornea, and that doesn't give a good cosmetic appearance. After 5-6 months, patient starts noticing that opacified peripheral rim.
Yes, sir.
So I have seen one patient with the opacification of the capsular bag when it is implanted in the bag. So it's better to do it this way, Dr. Anand's way, rather than putting it in the bag.
So we have one more speaker, Dr. Sohel Khan sir, still. So Dr. Sohel sir, are you there?
Yes.
Sohel sir, please, can you start your presentation?
Share screen.
Dr. Anand sir, please. Sharing your screen. Yeah.
Okay. PPT. My screen is visible now?
Sir, and you
Yes,
are audible.
yes. Okay.
Yes.
Okay. So this probably is the person who became the source of my inspiration, Dr. Takayuki Akahoshi, whom I had the fortune of meeting him. The limitation of the seasoned phacosurgeons, of course, we know that we are doing a high volume surgery, is obtaining pristine cornea day one without producing a wound burn in a very hard cataract or inviting a PCR like dreaded complication. And there is no single technique that suits the full spectrum of all the cataracts which we encounter in day-to-day practice. And as far as increasing the horizon of an MSICS surgeon, there is not a single true in the back fragmentation technique to increase the safety of the corneal endothelial profile. So pre-chop is the answer to overcome all that. And Akahoshi was the person who came up with all the types of force, but there is a steep learning curve, and there is a phenomenal interchamber stability because of the cross action, and there are different choppers for pre-choppers for different grades of cataract, and all they look like the same. So this is the introduction to a patented device, and it's a sleek one without a
Sohel,
cross
go
section.
full screen. Sohel.
Pardon?
Please go full screen.
Full screen.
Full screen.
Okay.
So down there is an arrow, the screen logo down at the presentation. make it full. There, down, yeah. No, down. Yeah. Right side. More, right. Yeah.
Is
Yes,
it
sir.
okay now?
Yes, sir.
Okay. So the only thing important is optimal capsular axis, harrow dissection, ensuring nuclear rotation, and the anterior debris need to be cleared. And of course, the most important bottom line is that you have to use a lot of viscoelastic. Go back to the video. Soft cataract. So this is a 1 minute very small video showing that how most of the time the soft cataracts are potentially intimidating for every one of us. So only thing is that you does all those maneuver, and this goes the Chang's chopper to hook the equator of the nucleus, and this sleek, elegant pre-chopper divides this into two. Once the soft cataract is divided into two, bringing each half into the iris plane and then emulsifying is not a big deal for us, and we overcome thereby all the possible problems like cheese wiring, going in close proximity to the poster capsule, producing a PCR, etc., etc. So we know that at times it is very intimidating and embarrassing for everyone to deal with an potentially soft cataract also. So this is a compilation of very short compilation as to how this pre-chopper wonderfully helps you in next week in disassembly of a soft cataract. To widen the horizon, I'm going to go for this small video which has got a voiceover also, wherein we are increasing the horizons of an MSICS surgeon. It's a small 2-3 millimeter. Presenting to you the world's smallest incision cataract surgery through an MSICS. MSICS is still resilient, relevant, and very effective alternate to instrumental phaco. Being independent of advanced machinery, it is cost-effective, safe, and ideal for resource-limited settings. Excellent visual outcome can be delivered when apt understanding of surgically induced astigmatism through incision location, shape, the configuration of the incision, the most important being the size of the incision. The mantra for success, therefore, lies in applying right knowledge and using the precise technique to minimize astigmatism. Phaco-fragmentation in antechamber sounds promising in reducing the incision size, but comes at the cost of endothelial damage. The snare, the Carmona, Vectis technique, bisector and trisector techniques are all very well described. Therefore, in the back, phaco-fragmentation remains the gold standard techniques, ensuring maximum endothelial safety and antechamber stability. Akaushi forceps, MyLoop, and femto lasers are all having their own intricacies and beyond the discussion of this. So get ready to witness for the first time in history a breakthrough innovation showcasing the world's smallest 1.7 mm MSICS with a novel, sleek, patented pre-chopper performing a blend of finesse and function, pushing the boundaries of precision, safety, and innovation in manual small incision cataract surgery. 1.8 millimeter mark is made on the sclera, and a scratch incision is made over the sclera with 0.5 millimeter back cut, and a corneoscleral tunnel is now being constructed. Two side ports are made as a paracentesis. Antechamber is entered with an keratome. An optimal size capsular axis is now being fashioned. Hydrodissection is done. Nuclear rotation is ensured, and superficial cortex is aspirated with Simcoe. The left hand engages a Chang's horizontal chopper to hook the equator of the nucleus, and with the right hand, the pre-chopper enters the antechamber, and both are brought together to produce a nice pre-chop. once the endonucleus is pre-chopped into adequate number of quadrants under AC maintainer and injection of copious viscoelastic through a microvectis, the subluxated fragments are evacuated from the anterior chamber. Cortex is aspirated and a foldable lens of your choice is implanted.
Stop. Next. Oh, stop.
So now get ready.
If I have time, I can present a hard cataract. Can I?
Yes, sir, you can.
Okay, so I'm going to hard cataract. This is the repentance of a cataract phacosurgeon, that why he has taken a very hard cataract rather than he should have taken a MSICS as an alternate.
So that phacoem indeed an upheaval task and is fraught with all forms of cataract, especially the harder one through the art of pre-chopping, which ensures obtaining pristine cornea day one post-op, which is usually a myth. I am showing the elegant, novel, patented pre-chopper. I am presenting this novel, sleek, elegant pre-chopper, which has got a reverse sickle shape cutting edge to perform the manual pre-chop. It has got a very pointed tip to pierce the core of the endonucleus. All these maneuvers are highly viscoelastic dependent. I am using through my side port a Chang's horizontal chopper, or I can also have the option of using a Akaushi ball sustainer in my left hand, and through the right hand, through the 2.8 millimeter incision, I am using this elegant, sleek pre-chopper. Once you hook the equator of the nucleus with the Chang chopper, the novel pre-chopper enters the 2.8 millimeter just anterior to the intercapsular margin. The pointed tip goes deep into the endonucleus, and both these instruments are brought together towards each other, producing a nice, elegant pre-chop. The forces, what you need to realize, are directed towards each other and are never towards the zonules. So the induction of zonular stress is quite minimal, and therefore this is a technique also conducive where you are anticipating a generalized zonulopathy as in PXF. Now, what is shown is an intermittent cataract, hard intermittent cataract, wherein the decompression has been done to decrease the intralenticular pressure. Capsulorhexis is performed, the anterior lenticular debris is removed by Simcoe, and here is the horizontal pre-chopper, horizontal chopper of Chang's design going into the side port, hooking the equator of the nucleus, and the pre-chopper goes towards the Chang chopper, and Chang chopper being brought towards the pre-chopper and to produce a nice nucleotomy. Once
Sohel
the
sir,
arc
please
rotated, you can have the option of performing as many as
I think I'm exceeding my time. Should I stop?
for that heminuclei.
Yes, sir.
yeah, please come up in the
It is
last few
now
minutes.
clearly
What you
evident.
also need
Yeah,
to
I will
realize
stop.
is that you can convert the entire.
So, any questions to the speakers, Dr. Anand?
Yeah. Yes. Dr. Sohel.
Yes, sir.
Yeah. Sohel, sir.
Yes,
I
sir.
would like to inquire, where do you get this instrument, sir?
Actually, it is being a patented one. It is marketed by AM Technologies from Nanded.
Okay.
Yeah.
So it is marketed and it is available only from
Yeah,
AM or
freely
some
available.
distributors?
Yeah.
Freely available. So we have to contact it.
Sir,
Yeah.
what is the minimum size of the rexis required for these two instruments? Because you are going to actually give pressure on the rexis if the rexis is smaller.
In soft cataract, you can make any compromise, even exceed like 4.5 is okay. But in a hard cataract, you ought to have a little generous, in the sense that
Yes,
you
sir.
need to have a 5.5 kind of rexis or
Single
even a
axis,
little
sir.
larger one, because
Larger one.
safety is important rather than like
Sir,
adhering to the
Yes.
norms. Yeah.
Is there
Sohel,
Yes, sir.
any incidence of breaking the either anterior capsule or posterior capsule? Because most of the tips, both the tips are quite relatively sharp,
Yeah.
especially for the beginners.
Of course, the most intimidating step, Dr. R.C. sir, is hooking the equator of the nucleus. Second one is, if your rexis is small, the torsional forces which are generated, they act like a torque. And if your rexis size is very small, then you can end up enlarging the rexis inadvertently. That is a possibility. But touch wood, I must say that the incidence of PCR has never occurred, as even I was learning the pre-chop, because the forces are directed towards each other rather than posteriorly, like in Akahoshi forceps. So they are
What is
never
the
direct.
what is
Yes.
the height of that sharp portion?
Almost it is 1.6 mm, 1.7.
Both of them.
Akahoshi, I am using the sustainer, which is available in the market. It is 1.7 or 1.75, say for example, to hook the equator of the nucleus. I am actually a fan of Chang's horizontal chopper, which has got a micro finger like configuration to hook the equator of the nucleus. So that height hardly matters. And the pre-chopper has got 1.6, 1.7 mm curvature. Yes, sir.
So there is a chance that at the end where the cataract is thinner, in
Yeah.
the center it is at the bigger side. So you have to go in in between the edge of the cataract and in the center.
Yes, because you start the pre-chopping right just anterior to the anterior margin of the capsular axis, which is a comparatively rather soft area. So rather than impaling the core of the endonucleus, which is a potentially hard area, so it is advisable. But of course, very hard cataract are not for the beginners or somebody who want to make a transition to. And fortunately, the patent has also been filed that we are coming with an ultrasonic tip of a similar configuration, which Dr. Dholakia is harnessing the phaco energy for producing the cutting of IL, or Pankaj Lande is showing excellent way of dividing the endonucleus. So we are about to come up with the ultrasonic tip for the this same design, so that can uh, go into the endonucleus quite deep.
Sir,
Yes, sir.
I just have you used our Dr. Rahul Bele's chopper? Because that will also give you a very means that angle what you want, that horizontal one. That also can help to hold this thing. I'm just asking because you are a
Yeah,
fan of
I have not
you
used,
are a
but
fan
my
of Chang and I am a fan of Bele's chopper, so that's
yeah.
why I'm asking.
I would definitely love to use it, but I have not used it. But my understanding of wireless chopper is it is probably because Dr. Rahul's is already available on the forum. So my understanding is probably it's a vertical chopper rather than a horizontal chopper.
My innovation is not at the tip of the chopper.
Yeah.
It is at the shaft of the chopper. I have given a bend on the
Angle,
shaft.
yes,
So that
angulation.
angle, yeah. So
No,
that
but
angulation is at parallel with the phacoprobe. And
Okay,
I can make almost 12 pieces of a cataract, any kind of cataract.
excellent.
So
Yeah.
minimum 12 pieces I make, not 4, not 8. I
Okay,
usually try to make 12, 6 of the half and 6 of the half.
but
So
it is
very
a
small.
vertical chopper.
Yeah, it's a vertical chopper.
Vertical chopper. Yeah.
So basically, it was a very nice session. Any more questions to the speaker? So I would like to thank the audience, all MOS members to make this happen. MOS Honorary President for this concept, Dr. Toric sir, the Secretary, Dr. Sean and Dr. Viral sir, and Chairman of Scientific Committee, Dr. Piyush sir, for making this innovative session happen. And I would like to thank all the speakers, the Chairman, Dr. Ladi sir, all the speakers who have spent their time, Dr. Jagdish Kakadia sir, Dr. Ramesh Shah sir, Dr. Sohel Khan sir, Neha madam, and Dr. Anand sir and Dr. Pankaj sir for wonderful innovative session. It was a galaxy of innovators from ophthalmology. It's a wonderful session, and I would like to thank the audio visual team, Mr. Ashwin from Mentor team, and Mr. Sunil from the technical team for this wonderful session. Thank you very much,
Rahul.
everyone.
Thanks a lot. Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you. Good
very
night,
much.
sir.
Thank you.
Good night.